Hello, everyone. My name is Laurie Hutcheson, and I'm the Executive Director of the Lobular Breast Cancer Alliance. And I'm so happy to welcome everyone back to this final session of the 2021 Virtual ILC Symposium, and the second patient advocate and patient-focused session. I'm hoping that today's session will help translate some of the science that we heard last week. And I'm going to share my screen now. Can everybody, I hope everyone can see this. So I hope that most of you had a chance to attend at least a few of the scientific sessions last week. And this is really just a recap of what was covered over the whirlwind of 2 days. The topics fell into 4 major categories. On day 1, the presentations addressed challenges in ILC pathology, diagnosis, and imaging in the morning. And in the afternoon, challenges in ILC research. Day 2 addressed new avenues in ILC research and featured one of today's panelists. And in the afternoon, the topic was lobular breast cancer biology. So the way we're going to have today's session go is that we're going to hear from each of our 3 panelists first for a total of approximately 45 minutes. And then we will be opening it up for questions and answers. And so we ask that as we go along, put your questions in the Q&A box, and we will keep track of them. And we are going to start with the panelists speaking about their takeaways from highlights of particular sessions from last week, as well as their own perspectives. And then we will turn to the Q&A. And I hope that we'll have a lot of time to get to all of them. I also have some questions that I know were asked last week that we can ask again today because they were not addressed. So you can just start right when the panelists begin. Please note we aren't able to take or address questions about personal issues or medical treatment. And before the panelists begin, I would just like to introduce them. These panelists are also members of the LBCA Scientific Advisory Board. And going first today is going to be Dr. Rachel Jankowitz. Rachel is Associate Professor of Clinical Medicine in the Division of Hematology Oncology at the Perelman School of Medicine at the University of Pennsylvania, and Director of the Rena Rowan Breast Center at the Penn Abramson Cancer Center. And Dr. Matt Sikora, who is actually going to go last, I think, is Assistant Professor of Pathology at the University of Colorado Anschutz Medical Campus, and Matt was the presenter last Friday. And Dr. Gary Ulaner, he is Chair of Molecular Imaging and Therapy at the Hoag Family Cancer Institute. And now I'm going to turn it over to Dr. Jankowitz, and just bear with me for a minute. I'm going to stop my slides and open up hers. Let's see. Okay. Dr. Jankowitz.
Thank you, Laurie. I'm so excited to be here this morning, and it was really an incredible 2 days to see how far the science has come for studying invasive lobular breast cancer. I started working with Dr. Steffi Oesterreich and Matt Sikora, Dr. Sakura, who's going to be with us today, and started talking about lobular breast cancer with them back in 2013 or 2012, and just to see how far we've come since then is really very exciting. I want to thank all the participants and advocates and patients who are here today. and especially thank also all the patients that have donated to these research endeavors and all of the presenters who have worked so hard to get us where we are today. So just, I wish I could cover everything that was presented in the meeting, but in 15 minutes, I'm going to just try to give more of an overarching view of the challenges that we still face, but the gains that we've made. I'm going to start by talking about some of the diagnostic challenges we face for patients with lobular breast cancer, talk a little bit about prognosis of ILC, and some of the preclinical research questions and findings that have been presented in the meeting. And then finally end with the therapeutic landscape of invasive lobular breast cancer and some future directions. You can go to the next slide. So as you heard about in the meeting, the diagnosis of invasive lobular breast cancer remains challenging in terms of the pathologic diagnosis. There are many pathologists who diagnose it based on morphology, and you can see the picture to the right of the screen here. The classic ILC morphology is the single cell tumor cells parading through tissue in a single cell pattern. Also, we use histology in terms of IHC staining for CDH1 loss. But there are differential diagnostic criteria across different pathologists. We also saw at the meeting evidence that there's been a problem with overdiagnosis when specimens are sent to central sites. They actually are not as often classified as lobular as they are in some of the local sites. And even things like heterogeneity and CDH1 antibodies used for staining by immunohistochemistry. So there seems to be an ongoing discordance between local and central pathology results that can lead to overdiagnosis of ILC. We know too that there are molecular ways that we can characterize ILC. The hallmark molecular feature is loss of E-cadherin, which is a transmembrane glycoprotein that mediates cell adhesion in epithelial tissues. And there are different ILC molecular subtypes that have been identified, but we don't ILC. So the question is, how do we move forward diagnosing ILC, and should this be a quote histomolecular diagnosis where we're bringing together, the classic morphologic features, the IHC, and Dr. Rees-Philo talked a lot at the meeting about the potential of artificial intelligence and how that could possibly be applied to histology to assist the diagnosis in a reproducible manner, and that exciting that presentation. So why is it important to develop a uniform diagnosis of ILC? Well, if our ultimate goal is to open more trials to be prospectively run for patients with ILC, we need to identify who they are. And we also, our ultimate goal would be to have targeted and specific therapies for patients with ILC. And in order to create eligibility criteria for trials and pick the appropriate patients for treatment, we really do need to work on diagnosing the problem. Next slide. Additionally, we heard a lot about prognosis of patients with ILC, and oftentimes when we come to these meetings, we have some new answers, but we're left with remaining questions. So how do we think about prognosis for patients with ILC? Does it differ across patients with various types of ILC? And how well do gene expression profiles help estimate prognosis for our patients? And do these gene expression profiles that we commonly use in breast cancer for the majority of patients who have invasive ductal carcinoma predict chemotherapy benefit for patients with ILC? You can go to the next slide. So we heard a little bit about the gene signature, which is also commercially called MammaPrint, in terms of predicting prognosis of patients with early stage lobular breast cancer. And Dr. Metzger and colleagues presented in 2020 some findings that were somewhat reassuring that the MammaPrint assay performs similarly for patients with ILC as it does for patients with IDC, at least in terms of prognostication for what we call disease-free survival, which I have indicated as DFS, and distant metastasis-free survival. So when you look at MammaPrint scores for patients with ILC, 16% of them are going to be classified as high risk by MammaPrint. But when you break it down, the analysis by Dr. Metzger and colleagues showed that only 10.2% of patients with classic ILC will have a high-risk MammaPrint score. But some of the different variants of lobular cancer could have a much higher chance, a 22.8% chance of having a high-risk MammaPrint score. So that is an interesting finding, and does indeed beg the question that perhaps different groups of patients with ILC will have a different prognosis, and that is based on differential gene expression in the various subtypes. So you can see on the slide here, though, that the MammaPrint assay showed similar 5-year disease-free survival estimates for ductal and lobular cancer if they were genomic low or low risk, and similar 5-year and 8-year estimates of disease-free survival if they had genomic high risk by MammaPrint. So that was a level of reassurance, again, that the test is prognostic in a similar way. However, it circles back to the fact that being that only 16% of patients with ILC are going to be identified as high risk by MammaPrint, are we missing some others? And are there other patients where there might be a better way to delineate risk? Next slide. Similarly, a lot of us are familiar with the 21 gene recurrence score, or Oncotype DX, and this is commonly used, at least in the United States, as a adjuvant chemotherapy decision-making tool. And when we look at use of Oncotype for patients with ILC, we more recently have defined a, quote, high-risk Oncotype as greater than 25, based on newer data from the TailorRx and the RxPonder studies. And at least when it comes to postmenopausal patients, a score of greater than 25 is necessitated or warrants adjuvant chemotherapy. And you can see that only 8% of patients, roughly, with ILC will have such a high risk score. But again, similar finding, 18.5% of patients with the non-classic ILC or the other variants will actually have a higher risk Oncotype score as well. So we're seeing sort of a similar thread here, where the non-classic variants are having higher scores. Next slide. So can we rely on the recurrence score to predict specifically chemotherapy benefit in patients with ILC? Similar to MammaPrint, I do believe that the recurrence score can be helpful prognostically for our patients with ILC. In terms of chemotherapy benefit, we saw one analysis in 2017 looking at SEER data with over 7,000 patients with ILC, where the high-risk recurrence score was indeed associated with increased mortality, so it was prognostic, but it did not seem to show benefit from adding chemotherapy to high and intermediate risk patients. We don't know why that is. It could be that this was a retrospective analysis. This wasn't, an analysis of a prospective randomized trial of chemotherapy. So we have to interpret those results with caution. And we did hear also Dr. Kriskin's group also showed no specific prognostic value of oncotype for patients with ILC, and basically their group showed that grade and lymph node status were still prognostic. So it's possible that we need to have a dual approach for patients with ILC, where we are still paying attention to grade, lymph node status, more traditional prognostic measures when using these tools to think about chemotherapy for our patients. So the answer is it's not a perfect system yet, but I do believe there are some patients with early stage lobular breast cancer that do need chemotherapy. Next slide. So is there a better gene expression profile for lobular cancer? We acknowledge that existing assays were not developed on ILC histology specifically, but they can offer us prognostic information. We did hear about the LobSig assay, Dr. Simpson's group, and that assay does seem to better stratify our patients with ILC, where what we see with MammaPrint and Oncotype is a very small percentage of patients, like I showed you, will actually be identified as high risk, whereas the LobSig assay seems to stratify more patients into the high and intermediate group. It was basically a third in each group, low, intermediate, and high. And interestingly, the high risk group by the LobSig assay was associated with the TCGA proliferative molecular subtype. And additionally, what they also saw in this high-risk group was that the group was enriched for certain mutations which can be targetable, such as the ERBB2 or Her2 mutations, and also were more prone to have P53, AKT, and ROS1. So this assay, I believe, shows promise and definitely warrants further validation for our patients with lobular cancer. In the meantime, I think that we continue to rely on assays like MammaPrint and Oncotype, and there are others that I don't have time to mention today, but essentially we use our existing assays in the clinical context of the patient. We look at stage, we look at lymph node status, we look at grade. Those are all important features. And we know that grade with lobular cancer is a little bit unique. So we can sometimes look at something called the mitotic index of the tumor as well. Next slide. So what did we hear about laboratory studies of ILC? And we heard a lot about laboratory studies, and I'm going to let Dr. Sakura get into more detail. But some of the things that struck me from the meeting that were very interesting to me were the discussion about the fact that a lot of our preclinical studies using ILC cell lines and mouse models, most of those models are ER negative, and that is a function, estrogen receptor negative. And we know that most lobular breast cancer is actually estrogen receptor positive. So that is a function of just the way the cells grow and the logistics of making these models. But what was really interesting to me from the meeting was Dr. Adrian Lee talked about patient-derived organoids and how they do a better job of retaining heterogeneity of the tumor in a way that cell lines do not. So in other words, when you grow an organoid model from the patient's own tumor, it can more faithfully represent all the different intratumoral clones in a way that a cell line cannot. They can also express estrogen receptor, and they can have estrogen-inducible gene expression. So it allows for more single-cell sequencing and a more in-depth interrogation of what's going on in that tumor molecularly. He also talked about the evolution of bone metastases and how even metastases within the same patient show genomic changes. For instance, they had one sample that acquired a somatic BRCA1 mutation, and how individual metastases can lead to therapeutic vulnerabilities. The challenge, though, is if a patient has multiple different metastases, all showing heterogeneous findings, genomic findings, and they've even seen heterogeneity in fibroblasts and immune cells in these metastases, all within the same patient. There's a lot of work to be understand which one to prioritize, in other words, and how do we know if one metastasis is expressing a somatic BRCA1 mutation, but another one is not, whether a drug that could exploit such a mutation like a PARP inhibitor would help everywhere or just in that particular metastasis. So it's an ongoing, very complex analysis, but I think that something that is really exciting to hear about are the ongoing rapid autopsy programs, such as UpTiter from the Levin program, and the University of Pittsburgh has a fresh tissue donation program from patients. And by patients donating tissue for the study of lobular cancer and other breast cancers, we can try to study all of these metastases directly from patients, hopefully in a way to further our learning about how to treat lobular cancer once it has metastasized to various sites in the body, where we can really see the tumor microenvironment and how the tumor is interacting with the host tissue. Next slide. So I have a slide here showing from Dr. Desmet showing treatment of ILC and ongoing clinical trials. And when I started writing TBCRC 037, which was back in 2013, I don't think we had any of these trials. So this is very exciting to see lobular specific trials. But when we break it down into the categories that she has it organized into here, we have some trials thinking about ER signaling and how lobular breast cancers respond to hormonal therapy. So the top left hand of the slide lists TBCRC 037, which is a preoperative trial of patients with lobular breast cancer. And I can show you that on the next slide. We have the alternate study, which is another preoperative neoadjuvant hormonal therapy trial, not specific to lobular breast cancer, but including lobular breast cancer. And then we have Dr. Metzger's PLOP study, which I'll also talk about, looking at preoperative endocrine therapy. So all of these studies are going to be looking at early stage lobular breast cancer and how the tumors respond to exposure of therapies that hormonal therapies that target estrogen signaling in the tumor. We also heard a lot about the meeting about activating HER2 mutations and how they are more common in lobular breast cancer than they are in ductal breast cancer. And we'll talk briefly about the SUMMIT trial and the MUT-HER studies that have begun to show that targeted therapies with drugs like neratinib can take advantage of these somatic mutations. We heard about synthetic lethality and that notion of exploiting CDH1 deficiency in lobular breast cancer. So we know that that is the hallmark feature of lobular breast cancer, loss of CDH1, and that opens up a therapeutic opportunity to try to target other agents that can result in synthetic lethality of the tumor. So the two trials going on in that setting are the preoperative Rosaline trial and the Rolo trial in the metastatic setting. And finally, we know that there is a subtype of lobular breast cancer called the immune subtype, and we have seen that based on some studies of lobular tumors that they can have more TILs or tumor infiltrating lymphocytes than ductal tumors. And so the Gelato trial is ongoing, looking at the role of platinum in combination with a PD-L1 inhibitor, an immunotherapy drug. Next slide. So this is the schema for TBCRC 037. This trial is estimated to be complete hopefully this winter, and it enrolls patients with hormone receptor positive, HER2 negative invasive lobular breast cancer, and the patients are randomized to 3 very commonly used drugs in the clinic, tamoxifen, anastrozole, or fulvestrant, for 21 days while they wait for their planned surgery. And the primary analysis will be to look at Ki-67 change, which has been linked to, it's been a surrogate marker of response to adjuvant endocrine therapy in breast cancer. And also we will be looking at full sequencing of the lobular tumors before and after exposure to these commonly used breast cancer drugs, so that we can try to understand mechanisms of response and resistance. Next slide. It's also very exciting to see that Dr. Metzger's group has completed enrollment on the PLOP study, which is very similar to TBCRC 037. It's a the difference is, though, it is a full therapeutic trial of neoadjuvant therapy. So instead of just being 21 days of preoperative treatment, it's a neoadjuvant trial, but there is a portion that similarly is looking at exposure to the hormonal therapies, and also in combination with palbociclib, which is a commonly used drug in the clinic, a CDK4/6 inhibitor. So we very much look forward to the analysis of that data. Next slide. So again, the 2 trials looking at the concept of synthetic lethality. This notion means that the lobular breast cancer cells in essence are CDH1 deficient. So if you could target another target in the cell that would exploit that deficiency and cause cell death, essentially, is the brief way to explain it. But ROS1 inhibitors are some of the drugs that are being used in these 2 trials to explore that concept. And again, the Rosaline trial is a neoadjuvant trial, and the Rolo trial is a metastatic trial. Next slide. And so the 2 drugs being used for the Rosaline trial, it's stage 1 to 3 invasive lobular breast cancer, and it's entrectinib with letrozole. And the primary endpoint for that study is RCB, or residual cancer burden. So that means how much cancer is left in the tumor in the lymph nodes by the time they get to surgery after being treated preoperatively with these drugs. And that trial is expected to complete enrollment in October 2022. The Rolo trial is a single-arm study for metastatic patients with metastatic lobular breast cancer, and that is combining crizotinib and fulvestrant, and the primary endpoint will simply be response rate to that regimen, and that's estimated to complete in May 2023. Next slide. So another really exciting topic that we heard about at the meeting was targeting HER2 mutations, and we heard a lot about several ongoing trials looking at a drug called neratinib in HER2 mutated non-amplified metastatic breast cancer. So what that means is, when we traditionally think about whether a tumor is HER2 positive, we think about overexpression of HER2 on a protein level on the surface of the tumor cells that the pathologist can see under the microscope, or we think about amplification of HER2, and that is commonly interrogated by FISH testing. So we have now seen that there are patients with breast cancer that do not have overexpression or amplification of HER2, but the tumor has HER2 mutations. And there are several ongoing studies looking at this concept. And so basically, we have the MUT-Her trials and the Summit trials. So MUT-Her, the initial phase of, I don't know if they call it, I guess they call it Mute-Her, sorry. The initial phase of Mute-Her enrolled patients with a Her2 mutation to neratinib until disease progression or intolerable toxicity. And the primary endpoint was the clinical benefit rate. And clinical benefit rate means for patients with metastatic disease, they either achieve a response to the therapy, a complete response to the therapy, or at least stable disease or no progression. So these were pretty heavily pretreated patients, and the clinical benefit rate was pretty high. It was 30%. And so that was an encouraging finding that the drug was actually achieving something in these patients with the Her2 mutations. So the second portion of the Mute-Her trial showed that neratinib in combination with fulvestrant, and then there was actually an option to add trastuzumab at the time of progression. Next slide. Oh, I'm sorry, previous slide. Sorry, go back to the previous slide. So what we heard from the meeting was that, from Dr. Bose, was that the response rate to this regimen appears quite good, and there is also an opportunity for dual Her2 targeting in patients. So what my takeaway from his presentation was that we should be thinking about combining neratinib with a drug like trastuzumab, perhaps in patients. And he even went on to propose a very interesting idea to study this in the early stage setting for patients with these activating Her2 mutations. And his point was that we would definitely need multi-site cooperation to do a study like that, because when you look at patients with lobular breast cancer, only about, I think, 8% of patients will have one of these mutations. So we're taking already a cancer that is 10% of all breast cancer, and now we're taking 8% of that 10%. So it would definitely require cross-site collaboration. But for the patients with these mutations, I think it's a very compelling finding that warrants further investigation. Next slide. And similarly, this is the Summit trial data presented at San Antonio in 2019. So this was another trial looking at patients' use of neratinib and trastuzumab and fulvestrant for Her2 mutant hormone receptor positive metastatic breast cancer. And so not all of these patients had lobular breast cancer, but 54% of them did. And very high objective response rate here of 53%. And again, so you see that dual Her2 targeting with the trastuzumab and the neratinib. And so more evidence that this could be an effective approach for these patients. Next slide. What about, a lot of patients are asking about immunotherapy for ILC. Is it going to work? How are we going to identify the patients that are going to benefit from that approach? We have the Gelato trial, which was a phase 2 trial of carboplatin and atezolizumab, which, again, I mentioned before, was an anti-PD-L1 antibody or an immune checkpoint inhibitor. This was presented at ESMO 2021, and the trial did meet its primary endpoint in that 4 out of 23 patients. And of the 6 patients who had clinical benefit on this trial, 4 of them had triple negative ILC, which is actually, as we know, unusual, because probably 85% of patients with ILC will have hormone receptor positivity. So the background to this trial was that the immune subtype of ILC has high levels of immune-related genes and high levels of TILs. Thought that there was a subgroup of patients with breast cancer where this type of approach could be therapeutic. However, when they looked at the data that they have so far, they didn't really see an association between clinical benefit from the drugs and stromal TILs. There was a trend toward benefit in PD-L1 positive tumors. So it left us with some questions, I think. So why are the stromal TILs or the lymphocytes associated with worse prognosis in ILC? Why are there low levels of TILs in the metastasis of ILC compared to the primary? And how can we find a way to leverage this strategy for ER positive ILC? Because the trial is trending toward it showing more benefit in triple negative ILC, which is actually kind of a rare subgroup of ILC. Next slide. So what are we left with? Future directions and questions. We do need uniform diagnostic criteria. We need multi-site collaboration. We need improved model systems to study ILC, and the organoid approach seems exciting to that regard. We need better diagnostic imaging for patients with ILC, and Dr. Ulaner is going to talk a lot about that today. We need prospective clinical trials for patients with lobular breast cancer, and ultimately we need ILC targeted therapies. As you can see, we're not quite there yet, but we are a lot further than we were in 2013, which is very encouraging to me. Thank you.
Thank you so much, Dr. Jankowitz. And I'm now going to let Dr. Ulaner share his screen.
Thank you so much, Laurie. Let me share our screen. And I hope you can see our the slide. My name is Gary Ulaner. I'm the Director of Molecular Imaging and Therapy at Hoag Family Cancer Institute in Southern California, where I like to think we are known for our outstanding sunny skies, palm trees, and molecular imaging. I'll try and be brief so that we have some time for questions and discussions at the end. I would start with this outstanding slide that was shown by
Dr. Ulaner, you're muted.
Hold on. Can you hear me?
Yes.
Can you hear me? I was told that I'm muted. Can anyone hear me?
I can hear you.
We can.
Okay. I apologize if there was any problem. Let me go right here. Are people still able to see the first slide?
Yes.
Great. Let me know if there are any other problems. Sorry for any difficulties. I will try and be brief so that we have time at the end for questions and discussion. My name is Gary Ulaner, and I am the Director of Molecular Imaging and Therapy at the Hoag Family Cancer Institute in Southern California, where I like to think we are known for outstanding sunny skies, palm trees, and molecular imaging. I'll start with this wonderful slide that was shown by Lee Pate and Steffi Osterreich, really giving a historical view of lobular breast cancer, in which for a very long time, lobular breast cancer was often thought of as synonymous, virtually synonymous to invasive ductal breast cancer, with thoughts like there are very little difference in survival rates between lobular and ductal, and there is no special consideration regarding its treatment between lobular and ductal. And I think conferences like the virtual ILC Symposium are really bringing to light that lobular breast cancer is a different disease than ductal breast cancer and needs to be approached uniquely. And the wonderful people that have been presenting here are helping to demonstrate the differences in detection, treatment, and future research that are really going to make care of patients with lobular breast cancer continue to improve. So there, for imaging, and I am a radiologist which specializes in imaging. For imaging, there are advances in lobular breast cancer in mammography, MR, ultrasound, but the one that was hit upon in this symposium was molecular imaging. So let me at least describe what is molecular imaging, and then what are the advances in lobular breast cancer. So each cancer cell, different type of cancer cell, expresses different targets within or on the surface of those cells. And we can think of those molecules expressed by the cancer cell as targets that can be hit. We can design agents that hit that target, much like a key fitting into a lock. And for molecular imaging and therapy, once we have that binding agent, that key, we can link onto it something that emits radiation. If it's a low amount of radiation, then we're able to get our agent bound to the cancer cell and use that to localize the cancer and image it in machines like positron emission tomography scanners. If you replace this low emitting energy isotope with something that emits very high radiation, then you can bring an amount of radiation next to the cancer cell that can affect a cell kill. Now, this is being used in neuroendocrine tumors, where there are now FDA-approved imaging and therapy agents, in prostate cancer, where there are new FDA imaging agents and soon therapy agents, and now breast cancer, and ILC is going to add that to that group of malignancies where molecular imaging and therapy is helping in patient care. Specifically in this conference, it was discussed estrogen receptor targeted molecular imaging, where the cancer cell is breast cancer. The target is the estrogen receptor, which for ductals, about 75–80% of ductal cancers express estrogen receptor. But the vast majority, 95% of more of lobular breast cancers express estrogen receptor. So it is an excellent target for imaging and therapy of the lobular carcinomas. The binding agent is estrogen, which binds to the estrogen. Estrogen is found physiologically within the body. And then it's linked to an isotope, in this case, something called fluorine 18, which emits a positron. And now we can bind to the estrogen receptor on invasive lobular breast cancer cells and image where those cancer cells are with remarkable high sensitivity. Now, this wasn't mentioned because this is already in clinical use, but I want to remind patients and patient advocates of this use of FES that is already available to them. If patients are on estrogen receptor targeted therapy and they unfortunately progress, the FES, this estrogen receptor targeted imaging, can be used to help determine if patients should receive a second line estrogen receptor targeted therapy, or if those medications won't work and you need to move on to other lines of therapies like chemotherapies. There is looking at patients that are estrogen receptor positive and looking at patients who are imaged with this fluoroestradiol, the FES, or what is now known as Cerianna. Those all names are all synonymous, fluoroestradiol, FES, and Cerianna. Of patients that respond to the ER targeted therapy, the vast majority are going to have high uptake on the FES PET scan. But probably more important is that if you take patients, if you look at the patients who do not reach a certain critical threshold on the FES scan, you can very reliably predict that these patients will not respond. Therefore, you can use this molecular imaging, the FES PET, on patients who are on ER-targeted therapies and who progress to help determine will they potentially benefit from a second-line estrogen receptor-targeted therapy, Or can you virtually guarantee that they will not benefit, and therefore they need to move on to other lines of therapy? This is just an outstanding use of molecular imaging, in this case, radiolabeled estrogen binding to the estrogen receptor, to help select therapies for patients with both invasive ductal and invasive lobular breast cancer. Here's an example of this, where a patient on our traditional FDG or sugar PET scan has multiple lesions detected. So the patient has multiple sites of malignancy, and this patient is estrogen receptor positive. But even though they're estrogen receptor positive, the radiolabeled estrogen doesn't find the disease. This highly predicts that the patient, because the imaging agent can't find the disease, the therapy agent won't find the disease either. And this patient should not receive further lines of estrogen receptor targeted therapy. Rather, they should move on to other lines of therapy. So this is what's currently standard and utilized in the clinic today. What was discussed by Dr. Hannah Linden is that there are now growing applications of using this molecular imaging, particularly for patients with invasive lobular breast cancer. We find that the molecular targeting of estrogen receptor is far more sensitive for detecting distant sites of metastases than the standard FDG PET scan and other forms of current standard of care imaging like CT and bone scan. And there are multiple research projects that are currently ongoing to help determine if this is reproducible. So there's a project being run out of the University of Utah. We at Hoag are running a research project, and GE, the company that is going to be marketing FES as Cerianna, it will be starting a research project to evaluate FES and its value in patients with invasive lobular breast cancer to determine if there is a beneficial change in management and beneficial outcomes. So why are there multiple trials looking at the same thing? Well, as has been said before, the word research is research because we repeat to make sure that the results are reproducible. And it's only if the results are reproducible that we put value that this is going to be useful for the wide majority of patients. So here, this is one step to the future, using FES as a specific molecular targeting agent in patients with invasive lobular breast cancer to detect the spread of disease more sensitively than is currently done with FDG PET or other standard of care. Now, to the next step, that is FES is currently being used in the clinic. Dr. Linden mentioned a novel agent which has been developed and first in human publications come from Washington University in St. Louis by Dr. Farouk Dadashti and her team there of specific molecular imaging of the progesterone receptor. And the progesterone receptor, PR, is pretty highly tightly linked with the expression of estrogen receptor. It's not 100%, but in many cases they go together. And their initial work, which was recently published in Nature Communications, demonstrates that this targeted imaging of progesterone receptor may be even more accurate at determining whether patients receiving estrogen receptor targeted therapy are going to respond to that therapy. And this is still an early phase work, so this requires that research, repeating for reproducibility, but there is just a remarkable cutoff here between non-responders and responders to estrogen receptor targeted therapy using this new agent called FFNP, which is an agent which binds to the progesterone receptor. So here, molecular imaging is going to be playing a growing role in the imaging of invasive lobular breast cancer both for imaging the estrogen receptor as well as imaging the progesterone receptor. And Dr. Jankowitz was discussing particular small numbers of invasive lobular breast cancers patients that have HER2 receptor changes, and there are agents that evaluate HER2 receptor molecular imaging agents that evaluate HER2 that were not discussed in the ILC symposium over the last few days. So this is now what I say is the critical future, defining these targets, right? The targets that we are imaging and using to target therapy. We now know that lobular breast cancer is different than ductal breast cancer. There is this seminal event, the loss of CDH1, which has defined lobular breast cancers, but there is now a growing number of targets that are different between lobular and ductal breast cancers, and it's these identification of new targets that allow us new imaging and therapy technologies that is really going to grow and benefit the care of invasive lobular breast cancer patients in the future. And then I show here are just a few of the many people, the real geniuses that are identifying these targets that then others are able to exploit. And this is a great transition for our next speaker, Dr. Matthew Sikora, who is one of those geniuses in the room. So thank you so much for the opportunity to discuss growing imaging advances for patients with invasive lobular breast cancer. And I'm really happy to, at the end, take questions either online or after. Thank you so much.
Thank you so much, Dr. Ulaner. I think that I can tell by both the time and the number of questions we already have that there will be an excess that don't get answered. And what we will do is collect all of them that aren't answered, and we'll work with the panel to get them answered later on. And we will be posting, I saw a few questions about the recordings and the recordings of the scientific sessions, and they will be made available. We don't have them yet. Not all of the presenters in the scientific sessions gave permission. So as soon as that is edited out, those session links will be made available. And I now want to introduce Dr. Sakura.
Great, thank you, Laurie. My name is Matt Sikora, and I'm assistant professor at the University of Colorado Anschutz Medical Campus just outside Denver. And it's also a pleasure for me to speak to you today about really the amazing advance in research we've had in ILC over the last decade or so. I want to highlight something that Dr. Jankowitz pointed out, that really that laboratory research on ILC has really only taken off over the last decade or so, but even within that time, it's become a really impressively international effort. The research today I'm going to talk about from the meeting spans 7 different countries, several sites in the US, and this doesn't even account for other active research groups in Ireland, in Washington, DC, and California. So really, it's, as Dr. Jankowitz alluded to, it's amazing what's changed in the last 10 years with regard to ILC research. So what I'm going to talk about today, I'm going to break down what we talked about at the meeting into 4 major areas of research. 1, defining the molecular drivers of ILC. 2, developing new laboratory models. 3, understanding better estrogen receptor function and anti-estrogen response. And then finally 4, the ILC tumor microenvironment. And we'll walk through these one at a time. So firstly, with regard to molecular drivers of ILC, Dr. Jankowitz talked a lot about LobSig and developing molecular signatures for how to understand ILC prognosis. So I won't belabor the point, but what I want to point out here is that all of the diagnostic signatures and prognostic signatures we have right now, such as Oncotype, MammaPrint, et cetera, they were all designed for IDC biology. And it's been reassuring to know that these signatures still work for lobular cancer, but really it's been smashing a square peg into a round hole. So we're really excited that LobSig, developed by Peter Simpson and his group in Australia, is finally an effort to understand ILC prognosis and predictive signatures based on ILC biology. Finally, they are building the square hole for the square peg of ILC. And we're excited to see how that develops and how they can validate that moving forward. Also, with regard to molecular drivers, Dr. Ulaner alluded to that characteristic loss of EC adherent. And I think some of the seminal work that has been done has been performed by Dr. Patrick Dirksen and his group in the Netherlands. And he's been focusing, among other things, on how EK-adherent loss changes tumor cell biology. And then how that then cooperates with changes in growth factor signaling. So that not only has identified areas that they can target downstream of that EK-adherent loss, but also what they can do to target this growth factor signaling pathway. So he talked about their efforts to identify those molecular drivers based on EK-adherent loss and how therapeutics can then take advantage of that. We had several outstanding talks on developing new laboratory models, one by George Slomos in Switzerland. And he talked about several efforts to develop new models of lobular breast cancer. My personal favorite was an adaptation of the common mouse model that we've used for breast cancer, where we can take breast cancer cells and grow them in mouse hosts to do treatment studies. But they've actually taken the approach to grow them, the breast cancer cells, directly in the ductal structures, when normally we haven't been able to do that in the past. But what they've learned about lobular cancer is that they grow in a completely different pattern in this model. Shown here on the right, you can see they grow in these little nodules in the end of the mammary ducts in mice, as opposed to ductal cancer cells, which kind of just spread throughout. And they're learning a lot about not only the in situ or precancerous state of ILC from this model, but then how it progresses to invasive disease and ultimately progresses to metastatic disease. So they recently published these models, so we're really excited to see how we can use these in the lab to collectively learn more about ILC progression and metastasis. Yeji An from University of Toronto talked about a mouse model exploring 16q loss. So we've talked a lot about, as a field, this EK-adherent loss, but EK-adherent loss happens in the context of a broader loss of this arm of chromosome 16, or called 16q. But we haven't been able to learn a lot yet about what happens when you lose that entire chromosome arm and how that impacts lobular cancer biology. So she talked about a novel model that they've actually deleted a huge chunk of the similar chromosome in mice, chromosome 8, that has a very similar region to the human chromosome. And they're going to be able to tell us more about how that entire loss of a chromosome, as opposed to just deleting a single gene, how that changes tumor progression and development. And finally, Dr. Jankowitz alluded to this as well, but the group in Pittsburgh is undergoing some Herculean efforts to not only characterize the lobular models we do have to learn more about them, since they haven't been included in larger studies, but they're also developing whole hosts of new models, including the organoid contexts, where they can take fragments of tumor here on the left, dice them up, model them in cell culture, and essentially develop new models that better recapitulate clinical tumors. And unsurprisingly, they look different in culture than matched ductal cancer models. So as their group in Pittsburgh develops more of these models, we're excited to use those as a field to learn more about lobular cancer biology in more relevant contexts. With estrogen receptor and anti-estrogen response, one of our talks was by Dr. Rena Hutcheson at the Dana-Farber in Boston. They've been looking at the genomics of estrogen receptor and how it actually acts on the genome, what's different between lobular cancer and ductal cancer models. And she showed a lot of exciting data, sort of validating what we've been thinking for the last several years, that estrogen receptor is doing different things in lobular cancer cells. Notably, it binds different places in the genome. It's associating in different regions with its key partners like FOXA1. And this is changing the structure of the genome in different ways, which will essentially change how lobular cancer cells not only respond to estrogen, but how they respond to anti-estrogens. And I'll toot my own horn a little bit. I talked on Friday about our efforts to understand why we have these differences with estrogen receptor function. And we've identified a unique partner of the estrogen receptor called MDC1 that we think lets the estrogen receptor essentially regulate its unique target genes in ILC. One potential consequence of this, though, is that MDC1 normally functions in DNA repair, and we think it's giving up this job in ILC as it takes on this new role. So there are potentially implications now for ILC cells having different estrogen receptor function, but potentially having compromised DNA repair. We have a long way to go mechanistically, but we're really excited about what this might point to as far as in the future and therapeutic development. And the last section I'll touch on is understanding the ILC tumor microenvironment. It's important to remember that when we think of any breast tumor, this is not a monolith of just cancer cells, but really it's tumor cells interwoven with the normal stromal cells, with endothelial cells that make up blood vessels, and with a whole host of other structures. So Dr. Val Brunton in Edinburgh has been trying to understand this better, and they've actually taken different ILC and IDC tumor models and taken apart the tumor cells versus the quote unquote normal structures that surround them, and have been characterizing what's different about those normal structural supports in ILC versus IDC. And one of their really interesting findings was that the normal fibroblasts, some of the normal cells that are associated with ILC rather than IDC, is they secrete some novel signaling proteins, and in particular interleukin-6, and this can radically change signaling in the tumor cells themselves. So they're finding new ways that the quote-unquote normal microenvironment in ILC is talking to the tumor and changing signaling in that context. And also in our keynote, Dr. Desmet at KU Leuven talked about the immune microenvironment in ILC cells. And I think my impression, I'm not an immunologist, but my impression is that ILC is turning a lot of the things that we think we know about breast cancer and immune cells on its ear. She discussed that having a higher immune infiltrate in ILC was actually associated with a poorer overall long-term outcomes. In this case, this dashed line at the left had the highest degree of immune infiltrate. And this is somewhat backwards from what we think of breast cancer as a whole. But despite this, so this argues that having less immune infiltrate is good, but we're also learning from her studies that recurrent ILC tumors, as well as those that metastasize, also then have a lower degree of immune infiltrate. So whereas in the primary tumor, having lower immune infiltrate was associated with better outcome, clearly disease recurrence and metastatic disease is not a better outcome. So there's clearly changes in how ILC talks to the immune microenvironment during therapy response and during progression that we have a lot to learn about. So just to quickly summarize, these are the 4 key areas we just discussed. And basically what we're taking is some major questions moving forward for those of us in laboratory research. Regarding molecular drivers of ILC, we're trying to understand what at the cellular and genomic level makes ILC unique, and then how do we develop therapies to target that. Regarding laboratory models, how can we best study ILC in the lab? Obviously, we wish we could do studies directly in patient tumors, but that isn't always feasible. So we need more and better laboratory models that better recapitulate what ILC is in patients. Several groups, including my own, were trying to understand why ILC responds to even just estrogens differently, and ultimately, how can we improve anti-estrogen-based treatment strategies based on that data? And finally, we want to know better about how ILC interacts with its local microenvironment, and most importantly, perhaps the immune system and how that will impact immune therapy use moving forward. Thanks very much for your attention, and I look forward to answering your questions.
Wonderful. Thank you. Thank all of you very much. And thank you, Dr. Sikora. So I have pulled all of the questions that we've received so far through the sessions. And I think maybe the fairest way is to bounce between them for all of you. And I think, so I'm going to ask Dr. Jankowitz if you can also uncover your camera, and because I was going to start with questions for you. If you have stepped away for a minute, I think maybe I will start with someone else. Oh, no,
sorry, I was just...
No, that's okay. Okay, so so one of the questions was, let's see, it was about enrollment in clinical trials. If a patient is interested in enrolling in any of the clinical trials discussed, what is the best way to approach your doctor, your team, and what are the pros and cons, and how do you discuss that with your doctor?
So all of our therapeutic clinical trials are listed on clinicaltrials.gov, but that website can be quite difficult to navigate for the average patient because there's just thousands of trials listed. So I think the best way to keep up to date about clinical trials in lobular breast cancer, specifically LBP, I think does a great job of curating that information. But if a patient is interested in a clinical trial, I think it's best that they talk about it with their oncologist. There has to be feasibility. I mean, just from a logistical standpoint, you have to be able to travel to get the therapies to whatever center is running the trial. So I think a combination of talking about it with your doctor and having an honest assessment about feasibility to do what's required for the study are indicated. some of these trials are run in Europe, for instance, and you can't do that from the United States logistically.
Great, thank you. So another question I will leave you to explain as well. Please talk about Verzenio. If you begin at an early stage, will a patient be immune to it in the future if they end up with metastasis? And is there a time that it's too late to begin?
So the reason this question is asked is a abemaciclib, which goes by the name Verzenio, has been presented to improve disease-free survival in an early analysis of the adjuvant trial. However, it is not approved for that indication, and it's not incorporated into breast cancer consensus guidelines to be using it in early stage disease. I think a lot of the people that set those guidelines really would like more mature data about whether using abemaciclib for patients with early stage breast cancer will actually improve long-term survival rates, or whether it is simply just potentially preventing early relapse or pushing it back further. There is some morbidity to the drug. It does cause diarrhea, fatigue, it can lower the blood counts, and the trial did implement 2 years of therapy. I don't know the answer. I don't think anyone knows the answer to whether, if we use it in the adjuvant setting, would patients be resistant to it in the metastatic setting? But I think the answer would likely be yes. If you are simply using the drug to delay onset of metastasis, then presumably when you become metastasis, it could potentially not work as well. So I think those types of unanswered questions, in addition to the lack of a clear survival benefit with it, that it has not yet gained full approval from the breast cancer community to be using it for patients with early stage disease across the board.
Great, thank you. And let's see, I'll give you one more and then switch around. So what is the current advice after 5 years of AI postmenopausal? Further continue with AI or switch to tamoxifen?
So for postmenopausal women who initiate their adjuvant therapy with aromatase inhibitor, there have been trials that have looked at 10 years versus 5 years of aromatase inhibitor therapy. And if you averaged out benefit of 10 years over 5 years, it's only about a 2.5% absolute benefit for the second 5 years. So the question is, who are the patients that really need it? And can we identify those patients? And it does come up for patients with lobular breast cancer, because we know that there is evidence in the literature that at least some of them can be potentially increased risk of late relapse, or what we call post 5-year recurrence. So I think when patients hit the 5-year time point, there are several things you can consider about extended therapy. Number one, how well they're tolerating the therapy, and number two, what their initial level of risk was with their cancer. And there is an assay called Breast Cancer Index that you can do on the primary breast tumor, and the test has been shown to be prognostic for late recurrence and predictive of extended therapy benefit. So for the patient who's sort of on the fence about whether to keep going and perhaps struggling with this decision, that can be a piece of the puzzle to consider when you're talking about it with the patient.
Great, thank you. Let's see, I'm going to have a couple of questions now for you, Dr. Ulaner.
Please call me Gary.
I will. So can you comment on how FES PET might eventually be integrated into ILC detection, surveillance, and monitoring of metastatic disease, or should all these trials that you discussed show benefit?
So that was well put, that these trials need to show reproducible benefit before it would make it into any guidance documents. My hope, right, would be that FES would be able to be utilized at multiple stages in the care of a patient with invasive lobular breast cancer, starting at systemic staging for patients that have advanced local disease, to evaluate for potential unexpected distant metastases, which would drastically influence how treatment decisions are made. There's also the potential for using it in patients who have been already treated, and then have a suspicion for recurrence, recurrent disease. Currently, CT bone scan is the National Cancer Comprehensive Cancer Network, the NCCN recommendation for that indication. I think a lot of people have finally come around to using FDG PET-CT for that indication, which works, in my opinion, better, but it's only an opinion. And then in lobulars, because lobular tends not to be so metabolically active, it doesn't take up FDG as well as the ductal tumors. You may need different imaging modalities, and I hope the FES will play a role here in the detection of disease recurrence.
Great, thank you. And a follow-on to that one, how does a patient find an FES scan? Is that available in every center? Does it take a separate machine? Does it take a doctor's order?
So great question. PET, the positron emission tomography scanner, is the same scanner. But you get different types of studies depending upon what agent is put into the bloodstream in order to search out those targets that we were discussing. So the typical FDG PET uses FDG, FES PET uses this other agent. So it's the same machine, it's just a different, it's what's in the syringe that is different. Now, FES is FDA approved, which means it is available to be used at any clinical center that provides FES PET imaging. But it's only approved for certain indications. And that major indication right now is patients who have failed one line of estrogen receptor targeted therapy. Should they receive a second line of estrogen receptor targeted therapy, or do you give up on that class of medications and move on to something else? And that's what insurance companies will reimburse for. So you can ask for an FES PET. The insurance companies are only going to, in general, they're only going to approve it for those FDA approved indications. I think the goal of the research trials that are available at the, we said, University of Utah, here at Hoag, and there will be a multi-site one opening up to be led by GE. Those will be to broaden the potential applications that patients can then receive FES PET imaging anywhere. So right now, for the FDA approved indications, you can receive this widely. For the investigational applications, you need to find a research trial. Otherwise, you're paying out of pocket.
Great, that's very helpful. Thank you. And one last one for you for the moment. What happens when one metastasis is ER positive and one is triple negative in a single patient, likely due to estrogen receptor resistance? Is this considered a triple negative, or is the patient still ER positive and should be treated with both targets, or just latest biopsy, or?
What a phenomenal question. And this is the growing problem of tumor heterogeneity. It used to be thought that if you had one receptor phenotype, that you were always that phenotype. And now I think it is becoming more and more recognized that this is not the case. Things change over time. And now, and I think our understanding of this is going to change with time. Right now, people say that about 10 to 20% of patients have this phenotype switch. But to me, that's just because we're limited. We're still limited on our rounds of therapy. As better therapies keep coming out, we're going to keep driving changes within the tumor cells, and we're likely going to start finding this more and more. So the question that was just asked really hits the nail on the head. This is a really important area for clinical care and research. So the short answer to that question is we just don't know, because there just hasn't been enough research in it to answer it. There's probably much longer possibilities to dive into, but for the sake of time, I'll let Laurie ask some more questions. And then if anyone wants to email me, I'm happy to discuss any more specifics that we have available.
Okay, great, thank you. The next question actually is for Matt. Can you talk about the best way that patients can contribute to basic research? We hear from patients frequently who want to donate their tissues to help advance research. And do you believe a central tissue bank to study lobular tumors and create models could be helpful? And in the meantime, what can patient advocates do to sort of help get us there?
That's a great question. I will point out first, I tried to answer a couple questions that were directed at me in the Q&A, and they're in the answered tab now. But regarding the question of what patients can do, undoubtedly a central tumor bank will be helpful. Any one center has a limited number of tumors that they can study, and a central bank would certainly improve collaboration. And LBCA is helping to coordinate that with members of the Scientific Advisory Board and other groups. So I think we'll get there. But obviously it's quite a logistical challenge to set these things up. In the meantime, I think maybe an underappreciated way that patients can help us is to advocate that lobular tumors need their own research. Right now, National Institutes of Health are only supporting 3 different trials, or not trials, 3 different grants on ILC research across all of NIH. And 2 of them are Dr. Oosterheik's. So it's really limited what NIH is supporting right now. And that's not entirely NIH's fault. That's just the field catching up. But advocating with your representatives and your foundations, local ACS chapter, American Cancer Society chapters, your Komen chapters, making it clear to them that that you feel that it's important that lobular research is supported with research funding is one of the most important things that can be done right now.
Great, thank you. So another question that came in while you were presenting, what would you say are the critical cells of interest for study contained within organoid models?
Yeah, that's a really good question. So I'll start with the cell lines that we mostly use that are easily the most common and the simplest model we have in cancer research are just cancer cells. That's all they are, and most of them have been growing in our petri dishes continuously for decades. Not literally one thing continuously for decades, but they were established back in the 70s and 80s, and we've been using them since. They're reliable, but they are only cancer cells, and they have certainly adapted to their conditions that aren't in a patient. Organoids, though, come directly from a patient tumor, and they not only include a set of cancer cells that better reflects the tumor that they started from because they haven't been in culture for years, they just started, but they will also include some of the structural, quote-unquote, stromal cells, like fibroblasts. They'll include a lot of the normal partners like the immune cells. And as I alluded to at the end of our highlights, those cells talk to the tumor and vice versa. So it's really important to not only have the heterogeneity of cancer cells that were there to start with, and Dr. Ulaner alluded to the importance of that, but also their partners. And Dr. Oosterheik and Dr. Lee are undergoing a really massive effort to not only build those organoids, but to characterize them. So we're going to learn a lot more about which partners are there in the models, how long they stay there, how the environment changes, and then ultimately that'll just help us with more and better models that look like a tumor rather than that simple, quote unquote, collection of cancer cells in a petri dish.
Great, thank you. So on the theme of research, to repeat, to reproduce, I think that this question is something we're all wondering, because protocols are not very different for ILC than for IDC right now. Is there a push to have the NCCN, ASCO, et cetera, define lobular breast cancer differently in their guidelines with different treatments to help our general oncologists And how can we get involved in making that happen? That's to any of you.
I think until we truly have targeted therapies for ILC, it's hard to mandate that they create different guidelines. I think ultimately over time, it would be great to see at least some incorporation of diagnostic criteria once we're able to agree upon a diagnosis. But in terms of therapeutic guidelines, as we all know, it's a frustrating point, but the current management strategy is technically not different. So.
Great, thank you. So Gary, back to you. Question, do you know if loss of imaging on FES is due to response or loss of active ER in metastatic breast cancer? You're muted, if you could unmute yourself. Thanks.
Thank you so much. So the question is the loss of the ability to see a tumor on FES, what is that due to? And they listed a couple of options, and the answer for there is all of the above plus more, right? So number one, if the tumor disappears, there's no tumor to visualize. So response to therapy is certainly a good way why you lose FES avidity. However, FES, this targeted imaging, one of its big limitations is that it only finds, it doesn't necessarily find the tumor, it just finds that molecule. So for FES, it's the estrogen receptor. And as we previously discussed, receptor expression can change over time, particularly with multiple lines of therapy. So you could lose the estrogen receptor. A tumor goes from estrogen receptor positive to estrogen receptor negative. You could still have tumor in your body, but now you lose the ability for FES to see it. And I think those two major possibilities are very obviously very different. In one, the tumor is gone, and in one, the tumor has changed, but is still there. So this is why I haven't mentioned FES as a method of measuring treatment response, because I think there are going to be some problems with measuring treatment response, because you could miss tumor that has lost its receptor status but still exists in the body. And it's also, so it's one of FES's biggest weaknesses, but then again, it's one of its biggest strengths, because this is its current application. If you have tumor in your body, but you've lost the estrogen receptor, you don't see the tumor, that tells you don't use estrogen receptor targeted therapies. So there are multiple reasons why you can lose the ability to see a tumor on FES. And there are both strengths and weaknesses to the fact that we're only seeing estrogen receptor, not necessarily the tumor.
Great, thank you. So Rachel, a couple questions back to you. You were answering the last question saying until we have targeted therapies, and so this question pertains to targeted therapies, and it's also like, when do you know? Like, is it repeat 3 times, and when it's concluded that it was effective, then it is considered a targeted therapy, and you might then be able to change your protocol related to that. Can you explain a little more for us what exactly a targeted therapy is, and the progression from discovering mutation in the lab to testing to trials, and how that all fits into our future therapies? Oh, you're on mute, I think, as well.
Sorry about that. So that's a complicated question. I mean, drug development generally proceeds through a sequential model where in phase 1 studies, the goal is to look at safety and tolerance and the maximum tolerable dose. And then when the drug progresses to a phase 2 setting, you're starting to look at efficacy. And then a phase 3 trial, at least in breast cancer, is a very large randomized trial that's considered to be unbiased, and you would be comparing it to whatever would be considered the current standard of care. In terms of, so any drug, whether you call it a targeted therapy or an immunotherapy, is going to have to progress through that sequence. For lobular cancer specifically, are there any targeted therapies that we can already use? So there is a section of NCCN guidelines that lists certain somatic abnormalities, that can be leveraged in the metastatic setting. For instance, if it's very rare in breast cancer, but if you had something like MSI high status, it's approved to use pembrolizumab. So we are starting to make incremental efforts to be tumor agnostic when we find a highly targetable finding like that. But what was the last part of your question? Sorry. So how are we going to get there is what you're asking.
And why is,
Yeah, so if some of the ongoing phase 2 studies for lobular breast cancer show promising findings, then I would assume that we would embark upon a multi-site phase 3 study, and that I suspect that would happen in the metastatic setting before the early stage setting. Generally, that is the sequence, but we hope that from our ongoing efforts with tissue samples from the early stage studies, we can inform the design of the metastatic trials, which will bring these drugs to the clinic faster.
Thank you. And one last question for you, Rachel. We all hear frequently from patients in online groups about how they might best work with their physicians to understand and determine if chemotherapy may be of benefit. And given some of the results from the studies of MammaPrint and Oncotype discussed, do you have any recommendations for how to use that information in conversations with doctors?
Well, so I think that patients are very anxious about the notion of being overtreated, understandably, with chemotherapy if it's not going to be effective. We have data that response rates in the neoadjuvant setting are lower for patients with lobular cancer. So the things that I look for are essentially lymph node status, grade and mitotic activity of the cancer, patient age, and then if I was using either MammaPrint or Oncotype, the things that we would talk about would be if you had a MammaPrint low risk assay. I think, especially I'm talking more in the node negative setting, especially for premenopausal patients, but that you could reasonably assure the person that they probably have a good prognosis without chemotherapy. For Oncotype, similarly, if the patient is postmenopausal and has a score less than 25, you could similarly reassure the patient they're going to have a good prognosis without chemotherapy, or chemotherapy is not going to be likely to modify their risk. The tricky part comes in for all the other patients that don't fit into, the 16% of people that are going to fall into those two categories. And there, I think you really have to take into account patient age is a big one. We know that younger women get benefit from chemotherapy more than older women. You have to take into account lymph node status. So leaving lobular out of it, when you look at the RxPonder data with Oncotype, we really weren't able to reliably identify a group of lymph node positive premenopausal patients that couldn't have at least some potential benefit from chemotherapy. So these are very individualized discussions, and I wish there was a one size fits all approach, but
well, as we're hearing, that's definitely not ILC.
No.
So we're just about a minute away. I don't know if any of the three of you have any last comments you want to make before we wrap up. I turn it over to any of you. You may have seen the questions in the box. Oh, so Gary, you're muted.
A big thank you to all the patients, patient advocates, and researchers that are all working towards this really important problem.
Well, I want to thank the three of you. This has been a really, really helpful dissection, I think, of a lot of what we heard last week. And there have been a lot of questions saying, can we get the recordings? The answer is yes. We don't have them yet. I'm not sure about the slides, but we will be posting information about how to access recordings from both patient advocate sessions and from the scientific sessions when they're available. And as I mentioned earlier, we didn't get to a lot of questions, and I'll be circling back with the panelists, and we'll hopefully get a document out with questions to everyone. So thank you all for coming. Thank you for all your advocacy. Thank you, researchers, for all your time and for helping us understand this better. Thanks, everyone. Bye-bye.
Thank you, Laurie.